The Majestic-1 study is a phase 1/2 study using Teclistamab. And Teclistamab is a bispecific antibody targeting BCMA that is constantly expressed by the tumor cells and CD3 in relapsed myeloma. And in fact, this antibody, this bispecific antibody Teclistamab, is redirecting the CD3 T cells on the tumor cells expressing BCMA, inducing the apoptosis of the tumor cells. So in the phase 1 portion of the study, we were able to identify the recommended phase 2 dose for Teclistamab monotherapy, that is 1.5 milligram per kg sub-Q. And then we are here presenting the pivotal phase 1/2 data from the 1.5 milligram per kg dose of Teclistamab. So the patient population, in fact, was heavily pretreated. All patients per protocol were triple class exposed to PI, IMiDs, and anti-CD38. And all of them were obviously in the relapse setting with a measurable disease. So the study design is very simple. In fact, during week 1, patients are receiving step-up doses of Teclistamab sub-Q in order to reduce the toxicity. And we have used 2 step-up doses, 0.06 and 0.3 milligram per kg. And subsequently, the patients receive the full dose of Teclistamab, 1.5 milligram per kg, weekly until disease progression. And we are here showing the data on the efficacy analysis on 150 patients. That is really a very large phase 1/2 study. And the safety analysis on 165 patients who did receive at least 1 dose of Teclistamab. Yes, in fact, it is important to consider the patient population, and they were triple class refractory for 77% of the patients, and pentadrug refractory in 30% of the patients. And the overall response rate for Teclistamab monotherapy is 62%, including 28% of complete response and at least 58% of very good partial response. So in this patient population, this response rate is very, very, very high, in fact, and well, those results are very good. And the median time to first response is very quick, very short, in fact, that's 1.2 months. So the responses are occurring very early, and the overall response rate was consistent across different subgroups of patients: high-risk disease, standard risk, patients with 1 or 3 or more prior lines of treatment. So very good results and very consistent results. The second part of the second results is the duration of response. And with the median follow-up of responders, that is 8 months, the median duration of response is not reached, in fact, showing that we have not only a very high response rate, but the response are long-lasting. We don't have yet mature PFS data, but the 9-month PFS is roughly 60%. So that's also very, very high in this patient population, triple class exposed, and for many of them, triple class refractory. Yeah, well, the take-home message is that with Teclistamab, we have a new agent that is off the shelf, immediately available, very convenient, sub-Q. We did not discuss the safety profile, but overall, the safety data are rather good, in fact, with a very low rate of cytokine release syndrome, grade 3 or more. That's only 1% of the patients. So very convenient, sub-Q, quite tolerable, I would say, with a very high response rate. And in very advanced patients, patients failing the usual therapies such as proteasome inhibitors, IMiDs, or CD38 antibodies. It means that potentially, based on this study, we may have an approval of Teclistamab in very advanced patients. And well, I think that that's a new tool that will be available in the outpatient clinics. That's also very important. The convenience and the sub-Q formulation is proposing this treatment in patients that are not staying in the hospital. And that's also very, very important for the quality of life.